looking for somebody right now here in town.
Okay, so welcome to Geriatrics and Gerontology Grand Rounds, and today we have Dr. Randall Frost, and he was kind enough to give this talk on the role of the healthcare provider in the medical examiner system. And Dr. Frost is the Deputy Chief Medical Examiner of the Bexar County's Medical Examiner's Office, and soon, as of January, to be actually the Chief Medical Examiner. And he's also the coordinator of the Forensic Pathology Fellowship of the Bexar County Medical Examiner's Office. And I think we all really need this lecture and hope to learn from it. And so, without further delay, I'll turn it over to you.
Okay, you might want to drop the lights just a little bit. There aren't a whole lot of gory photos, if any, in this particular lecture. Normally I have a lot of those, but this particular one is more on administrative matters and things, so should be fairly tame. The goal here is to give you a little refresher course on what the medical examiner's office is. A lot of people have very little idea of what we do. Even physicians are often not very conversant with us and our mission and what services we can offer. And the lay public, all they see is CSI and Crossing Jordan and other nonsense like that. So,
it's not like that.
No, yeah, sorry. So I'm going to try and tell you a little bit about it, and then we will get into death certification, which is something I know is the primary interest you have here. But I think first I have to sort of let you know what we do and what the law says we're there to do, and what we can do to help you. Now, let's see. Well, there we go. We're just right across the street, literally, right over here through the guard shack off Merton Mentor. And so we're there anytime you have a question. You can feel free to call. I'll give you some numbers later on who you can contact if you have any questions. We are a community resource. We have some primary responsibilities that we're supposed to take care of, but we view ourselves as consultants for any doctor in Bexar County or South Texas that wants to call up and ask us questions about death investigation or death certification. We will be more than happy to talk to you anytime. There's usually a doctor sitting at their desk, as not downstairs doing autopsies. If I'm not there, one of them could talk to you any time of the day, or even in the evening hours. We have someone on call all night long. We are a county agency. We are responsible basically for investigating and certifying deaths that occur due to unexpected natural disease or to violence, unnatural causes and things like that. We have primary jurisdiction here within Bexar County. That's where we can show the badge and take control of the body and subpoena records and all that kind of good stuff. We also, however, provide forensic pathology services to the majority of South Texas. We have about a 25, maybe 30 county area that we provide autopsy services for, because those small counties just cannot afford to fund the medical examiner's office. What we're not a county morgue. You know, we're not here to store all the bodies of everyone that dies in Bexar County. We are not an autopsy service. A lot of people think, well, we need an autopsy, call the medical examiner's office. That is most emphatically not what we're here for. We're not the health department. We are not the ones that make the rules on death certificates. We are just another bunch of doctors that have to abide by those rules just like you do. We have nothing to do with those regulations. And for that reason, we're not a death certificate service. We're not really here primarily to fill out death certificates. We are physicians, and when we have a case that we examine, we fill out that death certificate. Whereas, just like you're physicians, you have a patient, that patient dies of natural disease, then it's your job to fill out the death certificate.
If we did have somebody who wanted to pay for an autopsy, who would usually do that?
We're not allowed to do private cases at this time. Now, after the first of the year, we may change that depending on what the county commissioners say about a proposal I have for them. Right now, if you call our investigators, we have one guy locally who will do private autopsies for people. There are some in the surrounding area that will also do them for a fee. but primarily your own pathology department here.
Well, here, but
Yeah, here. If someone dies elsewhere, there are some private pathologists out there who will do autopsies. Okay, coroner. That's a dirty word to us in a lot of ways. There is no such thing as a coroner in Texas. And the quickest way to insult a medical examiner is to call him a coroner. A coroner is an elected lay person, heavy underline on the lay person. There are electricians, carpenters, bankers, whatever. Probably not bankers, they can make a lot more money doing something else. Most of them are clueless when it comes to what to do about investigating a death, yet they are elected and put into that position. In Texas, there is no coroner. The justices of the peace subsume that duty in all the smaller counties. So probably 235 of the counties in Texas have a JP responsible for investigating suspicious or unnatural deaths in those areas. They get about a week, maybe 2 weeks of JP school after they're elected. I think maybe 8 hours of that covers death investigation. If we're lucky, they are EMTs or nurses or something along those lines who have a medical background. Most of the time, that's not the case. They have to be 18 years old and have a pulse in order to get elected. Those are the qualifications. So that's why we take all these cases from South Texas, so that we can help these folks out, because they're really in deeply over their head when it comes to death investigation. And that's something for the legislature to work on. Unfortunately, we don't have anything to say about it. Now, a medical examiner is a physician, a medical subspecialist. We are all pathologists and forensic pathologists. We're trained in this, and we are appointed. The chief medical examiner is directly appointed to that position by the county commissioners of Bexar County, and then the chief medical examiner appoints deputies as needed to help him or her fulfill the duties. You'll only find us in the metropolitan areas in this state. The legislation provides that any county over a population of 250,000 may form a medical examiner district. Any county over 1 million must form a medical examiner district. And it used to be lower, but some of the counties got together and got the legislature to ratchet that number up so they didn't have to pay to fund an ME district in their counties. I don't think it's going to go much beyond 1 million, though. I think people are realizing that once you get to that size, you really do need to have a professional medical examiner system in place. In those areas, the medical examiner basically replaces the JP when it comes to death investigation. So justices of the peace in this county get off easy. They can run their courts, and they don't have to worry about going out to death scenes and trying to decide why Uncle Joe passed away. And most of them are very happy about that. Now realize that the laws governing medical examiners, coroners, etc. are different everywhere you go. Every state in the union has a different law. There is very little consistency in this. Texas has a pretty darn good law. It's about 50 years old, and it could really use some tweaking, but it's not bad. There are a lot of places where things are very disjointed and jumbled. Our staff at the ME's office consists of 5 staff physicians, including myself. We have 1, possibly 2 fellows each year. These are pathologists doing an extra year of forensic pathology fellowship training. We have a total of 9 investigators, 9 toxicologists, 5 autopsy technicians, about 7 administrative and clerical people, and then about 5 morgue clerks or autopsy attendants or morgue attendants. So we got around 40 people in the office. We're a medium-large office. We're not huge like Houston or Los Angeles, but we're a good-sized office. Full services. If we need it, we pretty much got it, and we can offer just about anything we need to determine cause and manner of death. Now, the law is what creates us. We are created by the Texas Code of Criminal Procedures. Same big bunch of books that talks about homicides and traffic deaths and things like that. It's basically the legal code of Texas, and it creates the medical examiner's office. It's what gives us the authority to do the things we need to do. As I said, we can subpoena people and records. We can compel people to give us information so that we can determine cause and manner of death. There is no confidentiality. when it comes to us. We're just like the police when it comes to our requesting records. It also lists cases that have to be reported to us, and since this is a criminal code, there is technically a criminal penalty for cases not being reported to us. Now, I've never heard of anybody getting in trouble for not doing it. Generally, it's, oops, I didn't know that I had to report that case to you, and we try to educate and help people out on that. We don't have any intention of sending the deputies down with a patrol car to put people in cuffs and haul them away or anything. But technically, there are some penalties for it. Our death occurs to cases of death due to other than natural disease. If it's natural disease, we are only interested if it is sudden and unexplained combined. Now, you may have an 80-year-old cancer patient who suddenly dies, but that's not a sudden and unexplained death. You may have somebody who's mowing the lawn, a 32-year-old man out mowing his lawn, and suddenly collapses and dies. That is sudden and unexplained unless he's had a bypass or something. And those are the cases we're interested in. We are primarily trying to determine a couple of things in our practice: cause of death and manner of death. Cause is one that causes a lot of problems for people, and this goes to death certification here, so I'll try to spend a little bit of time on it. The cause of death is best defined, at least the best definition I've found, is that condition or thing but for which death would not have occurred. We're not talking about physiologic mechanisms here like hypokalemia or cardiac arrhythmia, anoxia, etc., etc. We're talking about a concrete disease or thing that causes death. Cancer, stroke, gunshot wound, blunt trauma due to car accident. All the things that happen subsequent to those that you guys are interested in treating as physicians are really not what goes on the death certificate. We get lots and lots. We've reviewed most of the death certificates in Bexar County, or at least most of the deaths in Bexar County. And we see cardiac arrhythmia, cardiopulmonary arrest, respiratory arrest. Those aren't causes of death, those are death. Okay? There's a very big difference there. There needs to be a due to. If you want to put them on the death certificate, that's fine, no problem. Cardiopulmonary arrest due to atherosclerotic coronary vascular disease. Respiratory arrest due to chronic obstructive pulmonary disease. Come on in, we got some chairs over here. I don't bite or anything else. So that's what causes a lot of people problems, because physicians are interested in treating the problem, the thing that is about to cause the death, the electrolyte imbalance, the pneumonia, whatever. That's not really what the health department wants on the death certificate, though, and that's not what we're interested in determining. We're going back to that first cause that started the snowball rolling down the hill. Okay, so that's kind of a problem area for a lot of people because they're not used to dealing with that.
With that, that hierarchy where you have, what several areas.
Right.
It's all right to put cardiac arrhythmia,
right,
but then due to atherosclerotic cardiovascular.
Exactly. You can put, to us, the cardiac arrhythmia, the respiratory arrest, the hyperkalemia, those are mechanisms by which the cause of death causes death. So you can put them in there, but if you would, go back to that first thing. And I've got a couple of examples here of places where it gets to be really problematic. One thing to remember is time span is meaningless. And this refers to trauma cases primarily. If someone is shot in the back, becomes a quadriplegic because of spinal cord injury, spends 20 years in a wheelchair or in a bed, and dies of pneumonia 20 years later in a nursing home, that is still a homicide. It is the cause of death is a gunshot wound. The cause of death is not pneumonia, it's not quadriplegia, it's a gunshot wound. And these are the cases that we really are interested in getting. That's why we screen all the cremation death certificates in town, why we advise people to call us with all the deaths and we make a report on them. Because we pick up a lot of these cases every month where somebody is, they're used to dealing with this patient's been in the nursing home for 20 years, got a lot of medical problems secondary to the quadriplegia. The gunshot wound is sort of lost in antiquity. Nobody thinks about it anymore. But that's really what we're interested in. The rest of it, we really don't have a lot of interest in because it's not part of the death certification process, really. So time is meaningless.
When you
Yes.
say you're still interested in that, is that because you need to kind of marry that up with previous records and some criminal activity?
Well,
Or
we want to get the cause and manner of death right. That's the main reason we're interested in it. That's our mandate. Come on in and have a seat. Walk over here or something. The criminal prosecution of cases is frankly nothing we're interested in. And that's something else a lot of people don't realize. We don't decide when a murder's been committed or anything else. We just try to get the data right, and we give it to the DA, and they decide what to do with it. There are cases where people are prosecuted for homicide 20 years later when someone finally dies. So yeah, it can be important in that regard. Our primary concern is getting the data in there and getting the certification correct. These are, I'm sorry, did I hear somebody with a question? No. These are a couple of things that we see all the time that cause problems for us, so I wanted to mention them specifically. Seizure disorder. We get that on a lot of death certificates. If that comes across on a DC and nothing else, that's an automatic bounce. Goes straight back to our investigations division. They have to call you and start running down medical records and things, because a lot of times that seizure disorder is due to a remote head injury. Maybe an alcoholic who falls down a lot or has alcoholic seizures. Maybe someone who's been assaulted in the past has a seizure disorder. Doesn't really matter. We've got to find out why. And again, it's something that a lot of people are, this person may have been treated for 10 years for seizures, and the doctor treating him or her may not even know what the etiology of the seizures were. But it's something we have to dig into. Our biggest problem right now is this one right here, drug overdoses. We see many, many, many people going into the hospital with presumed drug overdoses, and they're never worked up. They'll do a urine drug screen which shows positive benzos, positive opiates, something like that. Absolutely a meaningless test. Urine drug screen is utterly meaningless. Tells you nothing. And that's from a pathologist that used to run a chemistry lab. It is, I wish that it were not even available, frankly, without doing it in tandem with a confirmatory test. Urine drug screens have a very high false positivity rate. They cross-react with everything in the book. The specificity is very low. Sensitivity is pretty good. It tells you nothing about the quantity or the type of drug. It may give you a class information like benzodiazepine. It doesn't tell you which benzodiazepine, doesn't tell you the concentration in the urine, and more importantly, it doesn't tell you the concentration in the blood. You can go into the hospital and have urine positivity for a variety of drugs with zero drug in your blood. The blood is what's acting on the brain, so that's the important thing. Anyway, enough preaching on that. What happens is we get these people that come into the hospital, obtunded, altered level of consciousness, and they are considered to be a drug overdose based on a urine drug screen, and they're treated for 2 or 3 days, and then they die, and then they come to us. The urine drug screen is meaningless. Any drug that was in the body has now been metabolized and excreted, and we're left shrugging our shoulders and saying, we don't know. So, if you have somebody that you think is under your care due to a drug overdose, if you can save some blood, preferably in a gray top tube, sodium chloride, or if you can do a blood drug screen with confirmation, that'll give you the data you need to confirm your diagnosis, and it'll give us the data we need later on, because it seems like most of these people now survive several days in the hospital before they finally pass away. Both of them have to be reported to the medical examiner too. We get a lot of cases that we pick up that are signed out as anoxic encephalopathy or pneumonia or something like that, never reported to us. We find them when the cremation request comes through. And some of the QA people in the various hospitals are kind of getting interested in this, so they may be after you on it. We have to be notified if there's any type of drug overdose. That's required by law. Time period, again, does not matter. And other intervening conditions don't matter. Sepsis, pneumonia, anoxic encephalopathy, none of that matters to us. Now, the a lot of people call up and say, well, he had heart disease and cancer and a couple of strokes last month, but I'm not really 100% sure why he died. Okay, you don't have to be 100% sure. The standard for cause of death is the most likely cause of death. So if you've got a differential diagnosis, pick the one that's number one, and that will work as your cause of death. No one expects you to be perfect on this. Even after we do autopsies, we can't be 100% sure on a lot of these things. The standard is a little bit higher when it comes to other than natural disease processes, but guess what? You can't sign those death certificates anyway. If it's other than natural disease, the only people that can sign that DC is us. So you're off the hook on those.
So what happens in the counties that don't have an MD's office?
JP signs them. Makes you feel good, right?
Yeah.
They sign death certificates.
And
Yeah.
JPs I've found can put pretty confirmatory sounding diagnoses.
Oh, they can. They can be.
For a
They can put anything they want on it.
Okay.
Hopefully, they have talked to their local physician if it's a natural death or whatever, and gotten some advice, or hopefully they've sent it up to us to look at. Now, I have seen cases where I called something one thing and the JP decided he didn't like that, put something entirely different down. Like I said, it's not a system I like, but we're stuck with it until the Texas legislature decides to do something about it. You know, we ask for it sometimes. We're a small group. There are maybe 25, 30 medical examiners in the state. There are quite a few more JPs. For some reason, they like holding on to that death certification. I don't know why. They do. If you've got elderly individuals who die an apparently natural death and you just don't have a great cause of death, well, our practice over the years has been to say, well, number one cause of death in people over the age of 60s is ASCVD. That's it. Now you can also put natural causes down, and that'll fly. The fact is that these are almost all natural diseases. When it comes to natural death, our interest level drops precipitously. We are still responsible for sudden and unexpected natural deaths, but we view our primary purpose here as dealing with trauma and unnatural death. So that's not something we're going to autopsy typically. Is you've got an elderly person with an obvious natural death. We're going to look at their medical history and go from there. It's perfectly all right to combine diseases or to put the "or" in there, like ASCVD or COPD. And by the way, I tell my doctors do not use abbreviations on death certificates because I've seen some that I don't recognize. Somebody may know what it is, but I've never heard of it. So it's better not to use them. Go ahead and spell it out. And if the health department doesn't know what it is, they'll kick it back to you, and you have to deal with it again. Okay, that's cause of death.
So you screen these, but the health department are the final.
The health department is the final say on whether the DC is acceptable. We screen them for one reason and one reason only, and that's to decide if it's the case that we should have looked at, but was not called into us.
And you screen every single death certificate that originates in Bexar County?
Not every one. What happens is there are probably about 12,000 people that die in Bexar County every year. About 9,000 of those are reported to our office. That's a very high report rate, but we like it that way. We're perfectly happy to do the extra work, taking those reports, because we get more information and we stand a better chance at picking up on things.
Reported by the funeral homes usually?
By the hospitals usually. We get calls from hospitals, nurses on the ward, QA coordinators, doctors. Anybody can call in and report a case with EME. Police, funeral homes, doesn't matter. Anyone can do it. The ones that we see at the actual DCs are the ones that come in for cremation. Now, with a lot more people being cremated these days, we see a lot of those. Before a body can be cremated, the DC has to come into us for us to look at it. And the idea there is you don't want to incinerate someone that may be a homicide or something that just didn't get reported to the EME's office. So we have a chance to look at those. And we pick up a lot of cases there. The other thing we look at pretty carefully is manner of death. Now, this is a concept that I do not like at all. I think it's silly. It's a vestigial remnant of the medieval coroner system that goes back to 11th century England. And I won't bore you with all the history, but it's kind of interesting. But basically we have 5 choices: homicide, suicide, accident, natural, and undetermined. Problem is, nobody can agree on them. They vary all over the map. People have different definitions that they use for these. Is a traffic accident fatality due to a drunk driver, is that a homicide or an accident? Evenly split nationwide. People are all over the place on it. So, I would like to get rid of this and just have a narrative on what happened, but it's not going to happen in my lifetime, probably. Most of these are fairly, yes?
The example that you were given, that the drunk driver kills somebody, I mean, would that be considered, so you're saying it could be an accident or a homicide, but for purposes of judging that person or maybe taking them to jail, if you put their homicide, is that going to be?
Doesn't matter. The DA does not care what we put down. They're not bound by our determination at all, and that's good. A lot of people think that if we call it a homicide, that's a murder, and the DA's got to prosecute. Not so at all. Same thing with the traffic accidents due to DWI. They're prosecuted all the time when it's called an accident. This is merely a public health classification for the epidemiologist. Nothing else. Doesn't matter in the court of law one little bit. As an example, though, that previous wound that I mentioned, gunshot wound to the back, paraplegia, pneumonia, that would be a homicide. Here in Bexar County, traffic accidents are called accidents, except for the hit and runs, which we call homicides. That's just based on tradition. It's been that way for 20 years, and that's the way it is. Again, forensic pathologists, by and large, pay very little attention to this as far as arguing about it. It's not something you can justify intellectually or scientifically. It is a semi-judicial function based on tradition.
Now, you said you're actually the only one that can put anything other than natural on there.
Anything other than natural, we have to do it. That's our case. Okay.
So a medical error is also an accident.
Medical error, no. We're not that interested in malpractice and medical errors. That's not really our job to investigate those.
So if we give the wrong antibiotic to a patient that was allergic to it, we don't report that to medical?
If you give it, that's a little different. Now, it gets a little fuzzy here. Just because it's an allegation of malpractice does not mean it's a medical examiner case. On the other hand, if it's giving the wrong medication or something that's not an expected complication of a procedure, like someone's in the OR and the OR light falls and crushes them, that's not normally what happens. Those things we need to know about. Somebody puts the nitrous on the oxygen line or something along those lines, yes, we need to know about those. The rest of them, go ahead and call us about it and we'll tell you if we're interested in it. Yeah, if somebody gets the wrong antibiotic and they die of an allergic reaction, we're probably going to take that case. But somebody that's being cathed and the catheter accidentally perforates something, normally we're not going to get involved in that. If we did, we would probably have to take twice as many cases every year as we do, because every operative death would have to be looked at. You don't find out about the allegations until 3 or 4 days later sometimes. It would be pretty unwieldy. And frankly, we're not in the best position to evaluate those kind of cases. The experts in that field are.
So those, the preparation, like you mentioned, so it's okay to make an entry in Part 1 or Part 2 of the DC? And is it reportable? Does that make it reportable to you?
It's one of those gray areas where it may or may not be reportable under the letter of the law. I would advise just go ahead and call us about it. But most of the cases that are reported to us, we don't take jurisdiction on. We say thanks, we'll take a few notes about it and make a little computer generated report, and that's it.
Okay, because if say you don't get the call on those particular cases, the death certificate goes to the funeral home goes to the health department,
Right.
And then you might still get a call from them also.
Probably not. I haven't seen the health department kicking back cases of therapeutic misadventures or things like that. We have not seen those coming back. I think they're pretty much on the same wavelength we are about that. If it's an expected or a known complication of a procedure, it doesn't really rise to the level of an accident, so they're not going to go any further with it. And it's a gray area. It's another one of those very fuzzy areas that's not really well defined in the law. That's why I advise go ahead and report it to us and let us tell you what we need to do with it. Okay, what cases are reportable? Well, if you look at 4925, this is the ones. You have to report any case that is a death in the hospital less than 24 hours after admission. I don't really like this one, but it's there as a net, a broad net to catch cases. That does not mean that all these cases are ME cases. The vast and overwhelming majority of them, we're going to say, thank you, not interested, go ahead and sign the DC and send them to the funeral home. Because most of these people have bad natural disease, they have a heart attack, they have cancer, and they come in terminally or something like that. There's no need for the state of Texas to get involved in it. But you have to report them to us.
Less
Yes.
than 24 hours to a hospital, does that also include long-term care facilities or skilled nursing facilities?
It says in a hospital. Now, if they are admitted directly from home to a nursing home, you might consider that. Most people make a stop at the hospital first and then go in. So, again, if you have a question about it, just call us. And like I said, most of them we're not going to take anyway. It's just a matter of a quick phone call.
Now, I have one particular question. I run the inpatient hospice here, which is, I mean, we are considered, our long-term care here is considered a, quote, separate facility, end quote, but we really don't treat it as such. And we'll always call you guys if somebody's, but most of our folks come from the hospital, main hospital down, and so if they pass away, if I get a guy who dies 12 hours after coming downstairs, for, usually this is a hospice issue, I don't call. But if I have somebody, what about coming from outpatient hospice, where normally, you guys would outpatient hospice in here 12 hours later after admission to the inpatient hospice unit, considered part of, part of the long-term care, physically attached to the hospital. I call you guys, and you seem disinterested. Should I continue to do that? Yeah,
okay. Keep on calling. It's not disinterested. It's just a matter of triaging the cases.
Yeah.
We want you to call us, but please don't take offense if we say no. We're not going to take that case. And we get called on most all of the hospice cases in town, and that's fine. Most of them are pre-registered, and we already know about them anyway.
So you actually get called by the... But who calls you, the hospice? Or?
Yeah, usually the hospice nurses call us, the nursing staff. We get them up.
But that's part of the protocol.
That's part of the protocol for most of the places in town. They just give us a call, and we make a few notes in the computer, and that's it. So we've been called, it's documented, you're off the hook. Nobody can ever say you didn't report the case. Nobody can tell us you didn't look at the case, and it's all there, so everybody's covered. Anybody that's in jail or custody, well, that kind of goes without saying, I think. Anybody who's killed, except judicial executions. We don't get the cases from Huntsville. If the government does the killing, we don't get into it. A lot of this is kind of redundant, unnatural. Yeah, if it's an unnatural death, we have to look into it. If it's an unwitnessed death, so someone who dies at home without being attended, even though they've got a medical history as long as my arm, and they were expected to die, we still have to be called about it.
When you say unattended, you mean someone physically, when you say unwitnessed, that's just kind of a...
Yeah, it means...
They're under the care of a physician, they may have
didn't
been seen a few months ago, so they're technically under the tenets of a physician.
Yeah, well, unattended means someone is there with them.
Oh, okay, literally, okay.
Yeah. Now, again, that doesn't mean we want to take all those cases, any cases.
And what usually happens is I get a call like from the police, and they say, we found your name on the pill bottle, and you signed the death certificate. That's after you've been called and
Tell them to find a JP.
Not in Bexar County. No, what happens on that? Every case in Bexar County will have a police officer called out to the scene if there's a death at home.
Unless a hospice death, they don't come out anymore.
Well, right, they usually don't own hospice because they've got someone else there.
Or they have the DNR.
Right. But usually that person will look around, everything looks fine, the door's not broken in, there doesn't seem to be any trauma on the body. and they will start looking around for documentation that there's a doctor associated with this person. They will call us, and then we'll usually call, or sometimes the police officer will call if they're on the ball and have some time on their hands, just to see if you're comfortable signing the death certificate on that. Now, we're fairly flexible on this. We understand if somebody dies at home, a lot of doctors are not comfortable signing that DC. And so we will bring those cases in and we'll do it. Now, I'll go through the process here in a little while, but basically, instead of this person going directly to the funeral home, they have to come into our office, and there may be a day or two delay in getting them out before they can get to the funeral home and all, and there's a little expense involved, and there's a lot of expense for our office. So if you can sign the death certificate, if this is a cancer patient who was terminal and expected to die, and the officer says there's no trauma or foul play, we would really appreciate it if you could sign those DCs. There's no contraindication to it, and it would help everybody out a lot if you could do that. Now, if they die in the hospital, we get pretty pushy about it, because if they're under the care of an attending and it's a natural death, we pretty much insist that somebody else sign the DC. Unidentified bodies have to come into us because we go to work on the ID. Cause of death is unknown. Well, yeah, but unknown doesn't mean I'm having trouble choosing between the top 6 terminal items on the differential diagnosis. That means I really don't have a clue why this person died. There's no medical history. We haven't had a chance to do a good workup, and we really don't know. And anyone under the age of 6 years old, the reason for that one is because our friends, the JPs, for years were signing out kids dead in cribs as SIDS without sending them in for an autopsy. And a lot of homicides got buried. So the legislature decided to do something about that. Now the confusion. Well, just because it's reportable doesn't mean it's an ME case and that we're going to take it under our jurisdiction. This means you got to report it to us. We get about 10,000. Actually, we think it's up to about 12,000 now. No, I'm sorry, 10,000 reported out of 12, 13, maybe 14,000 deaths. We only take about 2,200 cases into the office, and we're pretty busy. In order to do even a fraction of those, we would have to double or triple our staff, and the county commissioners might take exception with another $5 or $6 million out of the county coffers to do that. We make that decision based on the information we can get, the information from the police, information you guys give us, medical records, etc. And we try to get it right.
The reportable case that frequently comes up for me are the hip fractures, and then they die 6 weeks later or something.
That is a real problem. That is a problem nationwide. People have handled it different ways. We're currently kind of wrestling with that. What we generally ask is, okay, Ms. Jones fell and broke her hip. She had her ORIF and she went to rehab and she's back in the nursing home. Did she regain her baseline level of functioning? If she did, fine. We don't need to know about that. If not, was she bedridden and then developed bronchopneumonia? Yes, we definitely need to know about that because that's an accidental death, bronchopneumonia due to the hip fracture or mobility. A lot of them, unfortunately, are in that gray zone. Well, they're not back up to the baseline, but she's getting around, doing okay. Those we'll probably let go.
Which means that if we, even those reportable, we still sign the death certificate.
Right.
And you just review it and
Right. Well, call us up, and if we say, you know, it sounds like that hip fracture really does not have anything to death, if you agree, just sign the DC. Don't put the hip fracture on there.
Oh, okay.
If you put the hip fracture down there,
then
you are saying that it contributed to death.
And then you get it.
And then it's going to bounce back to us and take a long time. That contributory factor means that it helped someone die. It contributed to their demise. So just because it's a condition that they had, unless it actually contributed to death, don't put it on the DC anymore.
Not even in Part 2.
Not even in Part 2. Because that Part 2 means it still contributed to the demise. Okay?
So then just bronchopneumonia.
Well,
Respiratory failure secondary to bronchopneumonia.
for what? I'm sorry.
Respiratory failure secondary.
Due to bronchopneumonia? Yeah. As long as there's not a fracture or trauma or head injury or something that should be further down on the list, then we need to know about that too. If it's just an elderly individual with dementia and dies of pneumonia, that's it. Yeah. we'd like to have the dementia on there too, because that gives us an idea of what's going on. We see bronchopneumonia on a death certificate, and all the alarm bells go off, because we've seen so many cases where we look back into those. There's trauma of various types, hip fractures, all kinds of stuff. So if you can go ahead and put that final piece of the puzzle down there, it helps us to understand that yes, this is just a natural death. Off it goes.
Yeah, and I'd just like to add a comment to that. We actually, for a while, we were required to ask for autopsies on all patients, including our hospice patients. And we've got a manuscript submitted for publication on this. Basically, 80% of our hospice patients, all comers, cancer, non-malignant disease, dementia, heart disease, everything, 80% died with the pneumonia. And in the majority of those people, that was actually their mode of death. So, when he talks about pneumonia as kind of, well, that doesn't tell the whole story, it's because it is a common final pathway. I mean, it's not like if I died of pneumococcal pneumonia next week. It's not one of that in most cases. It's more of a final common pathway with a lot of stuff.
Yeah, it's one of those things like cardiac arrhythmia or cardiorespiratory arrest almost. It's more a mechanism of death as opposed to a cause of death. So we usually, our ears perk up when we see bronchopneumonia by itself, and we're going to have to spend a lot of time looking into that. Okay, these are the cases where we really need to know about them. These are true ME cases. Any type of injury or trauma contributed to death or caused death. That is a medical examiner case, and we need that one. We're going to bring it into the office and do a full workup on it. Anytime drugs are involved, and any time where the death is truly unknown, where the cause is truly unknown. No good differential can be put together on it. Now, we don't take cases just because the family or the doctor requests an autopsy. That's more appropriate for the hospital pathologist to do. We don't do private cases. We're not allowed to. So we can't really do that. Just because someone's alleging malpractice, that does not in and of itself make it an ME case. And whether a lawsuit's pending or not. I mean, you all realize that every hospitalized case, every patient is a potential lawsuit out there. So if you carry it to its logical extreme, we'd have to autopsy every death that occurred in Bexar County. And we don't want to go down that road. Now, death certification is actually a function of Vital Records Department of the Texas Department of Health. We are not the ones that make the rules, and we're not the ones that design the death certificates. We do sign an awful lot of DCs, so we can advise you on it, and we'll be happy to do that. If you've got somebody that dies and you don't really know how to word the DC, call us up. I've got some people that call me up on a regular basis because they like to do it. It makes them feel more comfortable, and I'm happy to talk to them at any time. 5-minute phone conversation is no big deal. However, if you want to do the cremations, those have to come through us. And if you want to take a body across county lines, you have to come through us and get a burial transit permit. Again, that's where we pick up a lot of cases that were not reported that should have been. Now, we get cases bounced to us. These are things that were not reported, and they get kicked back to the ME's office from a variety of sources. Sometimes the funeral home will look at a death certificate and say, that looks a little fishy, and they'll call us up and ask us about it. We may get something from the health department. If they get the final DC and they don't like the looks of it, they'll fax it over to us to look at. Vital Records in Austin, same thing. It makes it a little further down the line. And lawyers. Occasionally we get an attorney that sees a death certificate and sends it to us and says, hey, could you guys look at this? And you can guess what their interest is.
How about insurance companies?
Insurance companies usually don't, they want a death certificate and then they run with it usually. As long as they've got that DC, they're pretty happy most of the time. The purpose of bouncing these to us, at least in most cases, is to make sure nothing slips through the cracks and make sure all the trauma is adequately investigated.
But in counting through the JP system, where did they bounce to the JP then? Or?
Yep. That's it. There's no real authority to go back to there. Contributory conditions. We talked about this, but if anything goes in that Part 2 block that's traumatic, involves drug overdose or anything like that, that automatically kicks it into our ballpark and out of the natural disease category. So watch what you put in there. If it truly contributes to death, yes, put it in, and if it was trauma, then that becomes our case. But if it's not, if it's a hip fracture that was 6 months ago and really didn't contribute to death, just leave it out because it'll get bounced back otherwise.
We have this situation here in the VA where the widow will continue to get the pension for the service-connected veteran if the cause of death, if the service connection condition is somewhere on the death certificate, is the way I understand it. So, you know, we end up with things like PTSD that the veteran's been getting compensated for, and the widow will continue getting that if we put the PTSD on the death certificate, or if a lot of times it's traumatic injuries sustained in World War II. You know, if we, you can sort of stretch it, and you know, maybe the guy did die earlier because he had a shrapnel in his thorax from his Battle of the Bulge injuries. So.
Well, we get a lot of those, and we basically, we get these calls from families all the time, and we get sob stories and everything else, and we feel sorry for them, but we are very, very anal retentive about towing the line and making sure everything we put down is justifiable medically. And we've had some of those service-connected disability DCs, and we have scratched through that service disability because there's no way to support it, at least in our opinion. And we've had some family members angry, but you know, that's our job.
But those are the ones that go through you, right?
Those are the ones that come through us.
The ones that go straight to the
If it goes straight to the health department and doesn't get kicked back to us, as long as you can support it in your own mind as contributing to death, and it doesn't make it through us, we're not going to get involved in it because we have no way of knowing about it. PTSD, that probably wouldn't rise to the level of anything other than a natural anyway, really.
Yeah.
It's kind of hard to see how that would go any further, but shrapnel injuries and things like that, that we've had a few things like that where we've had some angst among family members, and we've discussed it, we've run it through the entire office, and in good faith cannot make a link between those injuries and death. So we have to leave them off. And we feel very bad that that causes people problems, but I think we'd all feel worse if we fudged. Because
there are backstop mechanisms for the VA physician to go, well, you know, I think the connection is here and throw it into veterans benefits.
Yeah.
I guess the question, you know, that I have is that, you know, I've always considered reporting to you guys, you know, the potential violent and direct impact of combat injury. You know, I mean, you know, for instance, gunshot quadriplegia, urosepsis, you know, World War I, you know, Iraq War, doesn't matter. You know, I don't report deaths associated with, you know, epidemiologically associated with Agent Orange.
we're glad.
You
don't have to report Agent Orange and Gulf
yeah.
War syndrome. You don't have to report those.
You know, I mean, you'll see, the diagnosis, even if it's a loose connection, the diagnostic connection will be there, and then I just let the VA fill in the gaps and determine whether that's backed up. But you know, I guess the one time, I actually think several years ago, I called you guys about a guy who I truly believe that his death was accelerated, you know, as associated with, you know, PTSD type of situation from prisoner of war status. Mm-hmm. You know, I felt that was not an unfortunate thing that this guy was stumbled upon, but, you know, I called it a natural death, but, you know, I felt that, no, this is, you know, somebody somewhere did something to this guy mm-hmm. and accelerated the process, as opposed to this guy was just in a bad place doing things he probably didn't want to be doing. That I report, but
yeah.
You know, the epidemiologically connected stuff I usually don't. That's nobody's doing that.
No, that's fine, and we get a lot of cases called in with PTSD on the diagnostic line, and that's fine. And we look at the case in toto and decide whether it's something we need to get involved in or not. Usually not, if it's that, unless it's something that's pretty severe. I mean, if they if they were in a POW camp and malnourished for 6 months or 2 years or something and never were themselves again, yeah, you can make a good strong ME case for that, but otherwise it's probably going to be harder for us to justify taking jurisdiction. Okay, signing death certificates. According to Texas law, and believe me, I've gone through this with the health department and the Texas Medical Board and everybody else extensively. Any doctor having knowledge of the patient can sign the death certificate. If you walked by, flipped through the chart, put it down, you have knowledge of the patient, you can sign that DC under the law. Ideally, you're talking about the family doctor, the hospital attending, the hospice attending, somebody who's dealing with them on a regular basis. The intern, the resident, the fellow, any of those people can sign. Don't have to have a Texas license if you're working in a federal healthcare facility. There's an exemption for military and VA under Texas law. You can still sign.
And trainees who are using their trainee license.
Right. Right. Institutional permit is just fine. Anything but a natural death, though, has to come through us, and that's the thing to keep in mind. So you'll get calls from us sometimes. So-and-so was found dead at home. We see he's got an extensive medical history. He's been followed on the ward here at the VA by so-and-so or by the clinic. Could you sign the death certificate? Again, police have been out. There's no evidence of foul play. If there's a good medical history, give some consideration to going ahead and signing that one, because it makes things a lot easier on the family and on everyone. But we're not going to force you to. The Texas Medical Board considers signing a death certificate as a professional obligation, and they have told me, their chief of the legal department said to me personally that it would be considered a patient abandonment issue if a doctor who should be signing it refuses to sign it. So bottom line is, you can't get in trouble for signing a death certificate, but you can get in trouble for not signing one. A lot of people are worried about getting sued for what they put on a DC. Can't happen. Won't happen. The only way you can admit it in court is to prove that death occurred. You can't be sued for what you put down as long as you do it in good faith. This is my best opinion at the time based on what I know about this patient as the cause of death. And that's the end of it. Certainty is not required. Bad reasons for refusing to sign a death certificate. We see these. If he's doing well, you know, haven't seen him in 6 months. Well, if he's this guy, probably doesn't matter that you haven't seen him in 6 months. Now, if it's somebody you're following for hypertension, okay, I'll grant you. That's one that you probably want to send to us. But use a little judgment on that. Not 100% sure why he died, neither am I, after I do a 3-day workup on him for several $1,000s. I wasn't there when he died, neither was I. Don't have the time, neither do I. Okay, we can keep on going. Scared of lawyers? Yeah, me too. And the ME will do it. A lot of times we won't. If someone dies in a hospital or in an institution and there seems to be a reasonable cause of death, we're not taking those cases anymore. At one time the office did. The first question out of the investigator's mouth is which doctor will be signing the death certificate. They have been instructed not to do that anymore. We're taking only legitimate ME cases in our office, and the rest of them we're not taking. We are buried under casework over there, and we're not getting any extra staff. So we'd like to share the wealth and spread the joy around on signing these things on natural deaths when there's an attending, there's somebody that knows the patient well. And can legitimately sign the DC. The funeral home's going to bring the thing to you. All you need to do is put down your I don't want to say best guess, your best professional opinion about cause of death, sign it, and check natural, and then let it go. And that's all there is to it. Funeral home does the rest. Although some hospitals do have offices that complete the demographic information. Okay, what happens when we bring a case in? There's a lot of misunderstanding about that, and that's one reason some people want the ME to take their case. They think they're going to get this big involved autopsy on so-and-so, and oftentimes it's not the case. Our investigators try to get as much information as we can about the case. Oftentimes, it's like pulling teeth, frankly. Getting records out of hospitals in Bexar County is very difficult, particularly on weekends or holidays. So you're going to know a lot more about the case than I am for a long time if you're familiar with the patient. I've got to play catch up from day one, trying to get records, try to read your handwriting. It's okay, mine's bad too. And try to go through the medical records, because I can't talk to the patient. That's my history. So go through those records. It may take me a week or more to get them. Body's going to sit there most of that time. We bring it into the office and we do an examination. Now we will do an external examination on everyone. Only about 2/3 of the cases actually get a full autopsy. If we do an external exam and there's no trauma and there's a medical history or the person's over 60 years of age, that's all they get. And they go out the door. So sending a case to the ME's office does not mean an autopsy is going to be done. But we're just going to do what's needed to determine cause and manner of death. We're not going to do autopsies and apparent natural deaths in most all cases. We're just going to do an external exam and sign them out based on your medical records. So again, if you know the patient and you're comfortable, it really makes more sense for you to sign it, because you're probably going to have more information on your patients than I will. Our autopsies are very different than a hospital autopsy, which is why I say in a lot of cases you want to get the local path department to do it. We gear our autopsies towards looking for trauma, determining cause and manner of death. We're not going to spend a lot of time subtyping tumors, looking for spread of disease, looking for the efficacy of treatment, and things of that nature. Most of the time, we don't even do microscopic examinations on our autopsies. Now, there's a few things that we ask all you guys to do when we do have a case. As I've said, medical records are our biggest problem. We live and die based on medical records. Without them, it's like we're blind and groping in the dark. Just like you have to have a history, we've got to have a history of some sort. Autopsies cannot be interpreted in a vacuum. They provide almost no information without something to get us started. If you have death notes, boy, is that great. Because I get a stack of medical records that high, and I've got 10 cases to deal with that morning. And it takes a long time to go through those records. So if there's a death note on there to give me a summary of what's going on with the patient, that is wonderful. We say very nice things about you when you do that. I like to get EMS and ER records, doctor's notes, tox studies, diagnostic radiology. The rest of the stuff is not as important generally. If we need medication records, nurses' notes, ancillary services notes, we can request those later. But if possible, we need to get those to accompany the body into the ME's office. And guess what? You don't have to worry about HIPAA when you're dealing with us. We are exempt from HIPAA. We don't care about HIPAA. They have no hold on us. So you don't have to worry about releases and all that kind of stuff. Toxicology, I've already talked about, but if you, please, if you think somebody is coming in with a drug overdose, grab a gray top tube and stick it in a refrigerator somewhere and keep it there until they either die or walk out. If they walk out, you can throw it away. If they die, please send it with them to our office. That may, you can get quantitative blood drug studies. Anytime a urine drug screen is ordered, there ought to be blood drawn at that time, so that if it's positive, you can then send that blood in for quantitation and identification. Okay? Nobody does it. That's the way it ought to be done. Any type of injury, if you can document that with a photograph, that's great. Unfortunately, the documentation on injuries is usually not very good on assault and homicide cases. And again, the reason is you guys are not here to document injuries. You're here to treat patients and save lives. So we don't expect you to do a forensic description of an injury in the medical records. And please don't leave any sharps with the body. I have had my staff stuck before because somebody left sharp objects in the sheets and everything that the body was in.
I'm sorry, what were you saying?
Sexual assault nurse examiners.
Oh.
Great, the commercial, please call us. Our investigators, 335-4011. That's who you call to report a case, or after hours. That's the only people that are open. they can get hold of one of us 24 hours a day. If you want to talk to a medical examiner, 4053 is our secretary, Wanda. She'll get you to one of us. If you want talks on anything to do with forensic pathology, call us. We do a lot of speaking on various things, and we find that there is a lot of misinformation about the ME out there and about this topic, so we like to go talk about it and try to clear things up. Some questions, anytime. I think that's all I've got on this. So if there's any questions, feel free to ask.
So do you have you talked about this hip fracture thing, and for purposes of documenting the morbidity and mortality associated with hip fractures, if we really think it's associated, we should put that on there.
Yeah, if you really think it's associated, it should be on there, and that will become an e-post. Now, there are occasions that we disagree. We've had some docs call up and say, I really think this fracture contributed to death, and we get the records in with the body and we look at it. We really can't say that the hip fracture contributed, and since we're the ones that are going to have to sign it, we go ahead and leave it off.
But that doesn't mean that you'll always get the body just because we
Right.
put it on the desk.